Dr. Vikram, I think you also got some uh, trouble to manage. Uh,
That's okay, Dr. Santosh. No
yeah.
issue.
Dr. Vikram, your voice is.
Am I audible?
Yeah, your voice. I think this is a problem from my side or some other.
Uh, if
Your
somebody
voice.
could,
Yeah, your voice is creating some other participants. You are getting the voice clear
Sir,
from the speaker side.
both are audible to me.
Okay, that's audible. Very nice. So now we are going to start today's webinar on World Mental Health Day. So I think we should start now. We have already 9:12 p.m. and the primary care has been a very important concern for primary care physicians, because right now the primary care is the care what we have to look into. Though our government of India, the Ministry of Health and Family Welfare, they are trying their best to overcome with the issues at the primary care, but still we have to do more. We have to travel a long journey to have a successful vision for the primary care and primary health care. If you're taking a particular segment to take care of to discuss about the primary care, that's a mental health. Mental health itself a challenge to address overall. That's why the World Mental Health Day is observed, is always observed on the 10th of October. And this year, we have a theme that how to be ready for during how to be ready for the emergency care. And in our setup, that we can understand the way the mental health problem is rising day by day. It is always a phase of catastrophic for Indian population, Indian youth, and to overcome with the that these all hassles, we have to start from the primary care. So we have our eminent speaker with us, Professor Vikram Singh Rawat, who is doing lots of work in the primary care. He's having the expertise in substance abuse and the primary care secretary he is dealing with right now in Uttarakhand. He is involved in many projects in collaboration with the National Institute of Mental Health and Neuroscience, NIMHANS, having lots of exposures in and leadership what he has developed in the Telemanas in the Uttarakhand right now. He's an additional professor in Department of Psychiatry. And that's today's webinar is very much important for all the primary care physicians. As I have mentioned, that the primary care is also not achieved that what we call is that weightage in the overall healthcare delivery system. The primary care has been little bit neglected what it should be, and the aim of the primary care to bring a transformations to connect its strategies towards the public health. So if you want a sound public health, so we need a sound primary care. I request Dr. Vikram Singh. And Dr. Vikram Singh, thank you very much. With a little, I mean, in very short period, we have informed you, and you, because your expertise in the primary psychiatry, and you became ready to deliver your word of wisdom with us. And I hope we'll be having a short discussion after this webinar. So I request Dr. Vikram, now over to you for the topic,
Thank you, Dr.
mental health
Santosh.
in primary care.
Thank you, Dr. Santosh. Thank you for the kind words. I'll just start sharing my screen. I hope my screen is visible to all.
Yes, sir, it is visible.
Okay, so I'll start off. So again, today's topic of discussion is mental health in primary care. Uh, Going ahead with it, when we look at the history and background, there have been multiple declarations which have occurred at different time points, and where we have looked at mental health is an integral part of physical health. So, along with that, an individual also has to be socially and economically productive in order to contribute effectively to the society. So, not just an absence of illness, but also being well and psychologically well, mentally well, and contributing productively to the self as well as to family as well as society as an individual. Now, there are three levels of healthcare service, what we know of primary, secondary, and tertiary. And primary, for example, PHC. At secondary level, we would have block headquarters or tehsil headquarters. And then we have tertiary care level where we have teaching hospitals or regional hospitals. These are some examples of how the care can be organized. Now, primary care means provision of essential health care made universally accessible to individuals and acceptable to them through their full participation, and where the country and the community can afford to maintain the care at every stage of development in the spirit of self-reliance and self-determination. So again, the principles involve equitable distribution, community participation, other than that, intersectoral coordination and use of appropriate technology. So these are some important principles which govern and wherein we are trying to make mental health care accessible, acceptable, and available in the community, affordable. Along with that, also other components like the mental health care should be comprehensive. It should involve coordination between different personnel and also being adaptable and appropriate. So again, what is the need for primary care in the context of mental health? The prevalence of common mental disorders is variably reported as to be somewhere between 17 and 46%. So that is substantially high and highly prevalent among any chronic medical conditions visiting PHC. Again, treating comorbid condition would substantially improve the quality of living. So it is very important for the doctor or the physician or the nurse who is there at the primary care level to be able to first identify these common disorders and also initiate some kind of a treatment or initiate a dialogue for further treatment and intervention. So when we look at it, the magnitude of the problem, there is a substantial amount of gap, around 70% treatment gap for psychiatric disorders as per the National Mental Health Survey, which was done in the first phase. Now again, there is another National Mental Health Survey which is ongoing. And this gap refers to a proportion of people not who are not unable to access treatment. And again, somewhere we need to narrow down this gap. And the functional treatment gap refers specifically to primary care, and it refers to patients suffering from psychiatric disorders but who present with physical symptoms and who have come to care settings and receive inadequate and sometimes inappropriate treatment. So there is a functional treatment gap due to lack of either recognition or being unable to treat appropriately. So this is another thing that we need to be aware of. So again, somewhere rational for integrating mental health care in primary health care. One is reduce stigma. Second is improve access to care, address comorbidity effectively at a primary health care level, and improve somewhere prevention and detection of psychiatric disorders, mental health disorders at a initial stage. So other than these, also treatment and follow-up can be improved by better accessibility, better financial affordability, and available acceptability. So again, this will reduce chronicity and improve social integration. Other than these, human rights protection, newer laws have become more rights-based and improving human resource capacity for mental health. These are some things which are very important, and these come across often when we treat patients. The challenges here are that they require investment in training of the staff to detect and treat mental disorder, and they need to address the overall reluctance of primary health care to work with people with mental disorders. and availability of time of PSC staff, availability of mental health professionals for adequate supervision, human resource management, adequate work conditions, payment, resources, availability of medication, support to carry out demanding work. These are some of the challenges which are often noticed. Now, WHO has initiated a MH gap program which aims to address this gap, and especially in the psychiatric and neurological disorders, and especially in low and middle income countries, wherein it plans to integrate specialized healthcare such as mental health care into PHC, and this is something which is critical to somewhere address the gap which exists. So again, when we look at it, the integration has involved preliminary situational analysis, funding, clear delineation of mental disorders, human resource training and competencies, recruitment, education of new PHC staff, availability of medicine, supervision and support of primary healthcare staff, effective referral system and coordination of a collaborative network, intersectoral approach and links with community services, and recording systems for evaluation and monitoring. Now, models of integration, these are different models of integration. One is traditionally coordinated care, where somebody in the primary healthcare level refers a patient to a general specialist, and the specialist is either available at secondary or tertiary healthcare level. And here, somewhere, primary healthcare will refer, and the entire management will be governed by the specialist. Co-located care, where both the primary care physician and behavioral health providers are physically located in the same facility. So this may happen in many of the community health centers. There might be an availability of psychiatrists as well as other health professionals like psychologists, clinical psychologists, and psychiatric social worker, as well as many other health professionals who are involved in mental health care delivery. The other system which involves is integrated care, where primary care physicians and behavioral health providers work on the same team, assume shared treatment plan of the patient. So again, integrated care can often be improved with the availability of technology, and that can help in substantially delivery of services at primary health care levels as well. So treatment of common mental health disorder is something very important in primary health care, especially depression and anxiety. These are something which can be easily screened for using simple tools like PHQ, GAD. These are certain tools which can help in immediately screening for a given disorder. Other than these, identification of substance use is something which can be done with simple tools like a drug abuse screening test, and positive screening results should trigger the PCB to ask questions regarding mental health system symptoms. And routine use of validated screening tools improves mental health disorder. So these tools are freely available and have shorter versions, like PHQ has two questions which can be used, PHQ2 to screen for depressions. Likewise, GAD has GAD2, which has two questions to screen for generalized anxiety. So these are some things which can be effectively used and implemented. Now, when we look at it, PCP should somewhere in the process of being trained gain comfort with common pharmacological interventions that are used in psychiatric practice, especially in the treatment of anxiety, depression, post-traumatic stress disorder, and substance use disorder. And they should consider psychiatric medications for patients with moderate to severe mental health symptomatology determined through use of a validated, reliable symptom screener. So again, they have to try to integrate their care with the mental health teams which are available, maybe at a block level or at a higher district level. And that can be effectively achieved with use of technology, teleconsultations, where supervised prescription can be something which can be used. And again, they can always clarify questions related to titration, switching, or monitoring parameters of psychiatric medications. Other than these, motivational interviewing and screening, brief intervention, these are something which are evidence-based and non-pharmacological interventions that can be used to bring about change in the behavior of an individual in the context of healthcare seeking. Some models which have been used, and one is Project Echo, which has used a hub and spoke model, for extension of community health outcomes. The project ECO stands for, and it has been used successfully to treat patients with hepatic impairment and who also have hepatitis, and along with that also have substance use. Now, other than these, there are other things which have been developed, including NIMANS has initiatives for primary care delivery, and they have started many training programs as well for primary care psychiatry. So these are some things which have been there. Now, again, the clinical schedules for primary care psychiatry by NIMANS is a 8-page document. And salient features here are it's a culturally sensitive screener and adopts a transdiagnostic taxonomy, brief counseling guide for all patients, follow-up guidelines, and comorbidity guidelines. This again can be accessed and can be used, as well as training is available for many primary care disorders to be able to diagnose and treat. Now, again, what we look at it, they have different modules through which they train. Basic module followed by telepsychiatry or on-consult tele-OCT module, collaborative video consultation and virtual classroom, and a public health module. So these have been developed, and many physicians have been trained with these, and they have been practicing treatment of mental health conditions in the primary as well as secondary healthcare settings. In conclusion, uh, somewhere integrating mental health care in primary care level would provide provision for basic first line management at primary care level and would help in addressing the treatment gap and also ensure better healthcare delivery, better curative and preventive measures, and also help to overcome challenges that are inherent to investment, availability of time and resource management. And somewhere PCP would have basic training in screening and management, and various clinician resources are available, especially something like DPCP initiative by NIMANS. These are the references. Right, I conclude here. I'm open to any kind of questions, clarifications. Dr. Santosh.
Well, thank you very much, Dr. Vikram, for a comprehensive insight for the primary care, mental health in primary care. Though what we have mentioned earlier that we have lots of challenges what we face while managing patients at the primary care, exclusively for the mental health context. So I request all the primary care physicians who have joined us, they can ask some question if they have while managing patients of mental health at primary care in their routine OPD to our expert. Questions and discussions, they can come up, please. Forum is open for discussion.
Sir, I need your permission to unmute all.
Okay.
Now the participant can unmute themselves.
There is a question in the chat box from Prapti. It says, particularly, how do we screen geriatric patients and what are the conditions which are common in them? So, Prapti, again, geriatric patients are a special population where what we need to keep in mind is one is cognitive impairment. So, often a geriatric patient may not be able to convey what condition they are having with accuracy because of cognitive impairment, which can often exist in them, which might be undiagnosed or which might be missed, or there might be a cognitive slowing. So, other than cognitive disorders which can occur, which can range from mild cognitive impairment to frank dementia. There are additionally geriatric patients can manifest with depression. Depression is not unusual, and the depression may not be easy to diagnose. It may be missed easily. It may be mistaken for a medical illness. So somewhere here, there are tools available in geriatrics which are used for screening for common conditions like cognitive impairment and depression, and these tools can be used. And other than these, there are elderly who will often manifest rarer disorders, which can include like psychosis, but those probably are better treated in a higher level setting, and probably best to treat depression, anxiety, and be able to screen for cognitive disorders in the primary care setting. So again, when you screen for depression, anxiety, Tools like GAD2, PHQ2 could be used. There are specialized tools which are there in geriatrics, but those probably, as if you're working with many more geriatric, then you can become familiar and start using them. I hope that is able to clarify. Okay, there is one more question by Nalini. Can patients with any chronic conditions be given tranquilizers to reduce anxiety? Okay, many chronic conditions can have significant amount of anxiety. By chronic conditions, I understand we are trying to say that are we referring to just mental health conditions or even physical health conditions? So if we are referring to physical health conditions and the anxiety is part of health related anxiety, it may be worthwhile to try to reduce the anxiety by some kind of a behavioral intervention or cognitive behavior therapy. But if there is no availability of a trained personnel for that, you could use medications, but tranquilizers or benzodiazepines may not be the best choice for long term because the patient is likely to get addicted and will have a rebound withdrawal, and in the long run, it may be difficult to wean off the patient from benzodiazepine. So in these cases, probably one will have to evaluate the need for, say, medications which are less likely to cause addiction, like SSRIs. So, and try to tailor the SSRI to a given individual's profile of clinical symptoms as well as tolerability of the medication. So, tranquilizers in the long run, probably not a good option. For a short period of, say, a few days to 1 or 2 weeks, one could use tranquilizers. By that, I only understand benzodiazepines because they are safer to use in the primary care setting. But again, depending on the age of an individual, suppose elderly, I would want to avoid because of one is cognitive impairment that they can cause in elderly, and second is uh, they are prone to falls and they can potentially injure themselves. So, case to case basis, one will have to carefully evaluate and take a decision. Okay, what is the impact of humanitarian emergencies on the mental health of children? This is another question by Nalini. Again, mental health of children is a topic which needs attention in itself. And depending on the age of the child and what kind of humanitarian emergency they have been exposed to, it can substantially affect their development, especially their emotional regulation, their ability to adapt to others, and how they relate to strangers. They may have attachment difficulties. So here somewhere again one has to be careful and sensitive. The parents' version, the version of teachers may help us in getting to know what kind of an reaction a child is having, and of course talking to the child and assessing the child in a longer run, observing the child will help us in trying to reach a conclusion as to what kind of an impact a child is having. And a child can have all kinds of emotional responses which may appear inappropriate, and difficulty in attachment with the family figures or figures who are considered significant, and may not be able to form friendships or bonds. So there might be a lot of changes in the child which may be evident. I hope any other queries in the chat box, or somebody would want to unmute themselves and ask some questions.
Johnny, yes, Papa. Eating sugar? No, Papa.
Hello.
Yeah, if there is no question from other side, Dr. Vikram, may I ask one questions from
Yeah.
all the primary care physician? What I feel,
Yeah.
do the primary care physician have any reservation to start SSRI or antidepressant in their primary care management of any patients of depression or having the mental health problem?
What I expect is there will be a reluctance on part of anybody who is not familiar with a given medication. Suppose an individual has never prescribed SSRI or dealt with patients with depression, they'll definitely be not in a comfortable space. So if I am not a physician who's treating diabetes, And if somebody asks me to treat diabetes with, say, insulin or some medication which I'm not familiar with, there will be an initial phase of anxiety as well as concern. So here, and also at an MBBS level, how much we are trained, at an internship level, how much of exposure to psychiatry we have, and what kind of comfort level is there is something which matters. Despite that, it will be definitely possible for an individual with some amount of mentoring, shadowing to be able to prescribe SSRI and use them effectively. We often see that people in private practice often use SSRIs liberally because patients often have somatic complaints, anxiety, which is magnifying their physical symptoms or physical illness. So somewhere here they are used often, but case to case basis, one will need to make a decision. But definitely it can be used. Probably it is underused. The SSRIs are underused in primary care setting because of apprehension or fear that the primary care physicians or practitioners may have. So definitely there is a case in using Dr. Santosh, and it is worthwhile to often, if they have any doubts, to clarify and also to liaise with any team. And with telemedicine services, it might be worthwhile for an primary care practitioner to always take help and be guided on their prescriptions while discussing the details of the case. So something that we do even in our outreach programs at tehsil level in Munsiari, and which have been practiced in many parts of the country as well, that somebody sitting in the remote tehsil or block or PHC is able to do a video call, discuss the case in detail, and also decide on what prescription might be appropriate and what adverse effects they'll need to look out for. So individual to individual, every medication has its own profile of adverse effects and how they manage. There can be occasionally some difficult adverse effects to manage, which may need more attention. But generally, they're fairly safe. The medications SSRIs are fairly safe. There isn't much of a risk of serious adverse effects in most cases.
Okay, thank you very much, Dr. Vikram. And it was really rightly said by you. It's a huge apprehension to start sometime SSRI to treat a patient of depression in the primary care management. But we could understand, we were very finely understood you that until we are not very much clear that it's a need of SSRI to the patient, and we need to have primary care physician need to have a good exposure of treating or assessing a case of mental health. Who he should be able to make a diagnosis of the depression or anxiety disorders. Then better they should start SSRI. And what I would recommend is not to overuse. What Dr. Vikram had mentioned, it is underused in the primary care. But what I would like to request, please do not overuse SSRI as it's become problem for the patients as well. So, any other questions you would like to?
The chat box, I see Nalini has a question. Are there any online courses for primary care physicians? Again, online, completely online, I don't think so that there is a completely online course. NIMANS has a digital academy which does deliver many courses, and many of them are specific to given conditions, say substance use disorders, or sometimes even like what I mentioned, a clinical schedule of psychiatry for primary care physician. So the DPCP program, these are there and one can enroll, but that will also involve some kind of shadowing, mentoring, like what I said, different phases in which an individual will be trained. They'll have to take cases, present to them, and there will be a discussion, and there will be peer feedback and mentoring. So these courses are there, and NIMAS is delivering quite a few of these courses, and one can definitely get in touch. If somebody would need help, I will share further details with them. Okay, Elizabeth would want to be unmuted. Could somebody unmute Elizabeth?
Yeah, I am unmuted. Can you hear me?
Yeah, please.
Because in elderly people, like how like isn't it depression often missed because already they are slow in their activities, and maybe their cognition level is low, and sometimes in bedridden patients we we presume that it's because of their old age. We may be missing hypothyroidism also, right? So how often should we think about this hypothyroidism, and maybe depression is also resulting from the hypothyroidism? So how often
Yes.
should we check all this, think about it?
Elizabeth, it's a good question. Elderly, definitely they have medical illnesses many a times when we see them in the hospital setting, and there might be more than one medical illness. And like we always follow that in presence of a treatable underlying disorder, suppose an individual is having a treatable underlying hypothyroidism, we would want to treat that to the fullest and see if the person comes out of the depressive symptoms and the presentation which is looking like depression and maybe a manifestation of hypothyroidism. So there is no doubt about it. But often it may so happen that the hypothyroidism may not be very severe and the extent of depression might be much more severe, in the sense patient may have psychotic symptoms, whereas the hypothyroidism may be only marginally they might be hypothyroid, but patient may have nihilistic delusions. So in these cases, probably you will need to look at if there is an additional diagnosis of depression which needs further intervention and treatment, medications, and sometimes rarely other forms of treatment like ECT may be necessary to bring the patient out of their severe depressive episode which is there. So it is just a detailed clinical evaluation, weighing of all the available parameters, blood tests, investigations, and serial assessments of an elderly, which will give us clear picture as to what will happen. Sometimes still there is doubt, and giving it a benefit of doubt, we could cautiously give them low dose medication and slowly observe if the depressive symptoms were to lift off. So still it can be difficult sometimes in elderly, but your question is very relevant in the context of elderly. Are there any other questions?
Okay. If there is no questions, I would be very much thankful to Dr. Vikram for sparing this valuable time and making lots of confusion clear at the primary care level. And primary care management and primary care concern has always been important. And I'm very happy that you became ready to address these all issues, these all concerns in a short notice. I'll be very much happy, and
Thank you.
I am very much thankful to you. And I'm very thankful to all the participants who have patiently here and patiently having a discussion with the experts. Thank you very much. We'll be continuing this type of session again under the banner of API Uttarakhand, and I hope we'll be having much audience next time to interact, and we'll be definitely coming out with a new strategy and a new way of tackling primary care issue in another disease. So thank you very much, ladies and gentlemen. Having a good and great night. Thank you. Thank you, Dr. Vikram. Thank you
Thank
very
you.
much.